Right, we are live. You are ready?
Yes. Hello.
Hello. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 15E, which is Hematology Erythrocytic disease. We are streaming live from GMC Kottayam, Kerala via Kolkata. A very pertinent topic today, which is anemia of chronic disease. And to talk on that, we have somebody who is a star, Dr. Jayapriya G. She is an MD Pathology from GMC Thiruvananthapuram with a PDC on Oncopathology from RCC Thiruvananthapuram. Presently, she is an assistant professor in the Department of Pathology, GMC Kottayam, Kerala, with her areas of interest in Cytopathology, Hematopathology, and Oncopathology. Before I ask Dr. Jayapriya to start, let me request you to keep your mic muted, your camera off, and please do not share.
Okay. So today we'll be dealing with anemia of inflammation or chronic disease and the anemia that is associated with other systemic disorders. So first we'll go into anemia of chronic disease, also known as anemia of inflammation. So anemia, this anemia of chronic disease, it was traditionally it was described as the anemia that is seen in patients with any infectious, inflammatory or neoplastic disease that is persisting for a prolonged period, that is more than 1 or 2 months. But later on, as our understanding of this disease increased, we found that even in patients admitted in ICUs, they develop anemia within a matter of few days. And even in aged patients and patients with obesity, you can see any development of anemia. So it was understood that it was not the chronicity of the process that was important, but rather something else that was causing the anemia in these conditions. So it was known that it is the inflammatory background in all these conditions that eventually led to the development of anemia. So now anemia of chronic disease is actually termed as anemia of inflammation because of the basic inflammatory pathology in all these cases. So it is the most common anemia in patients admitted in hospitals, and it is the second most prevalent cause of anemia after iron deficiency anemia. Now coming to the conditions, as already told, it need not be always a chronic condition. So most commonly it is associated with infections, malignancies, immune diseases like rheumatoid arthritis, SLE, vasculitis, IBD, etc. Also in chronic kidney diseases, chronic liver disease. Besides, you can see this anemia of inflammation in other conditions which I just said in the previous slide. That is, we can see anemia of inflammation in elderly patients, in patients with obesity, even in congestive heart failure, and even in patients admitted in critical care units. So the characteristic feature that is a hallmark of this anemia of inflammation is two things. One is the presence of hypophoремia, that is, there is very low serum iron, but you can see ample reticular endothelial iron stores. So the iron stores are there, are increased, but the same cannot be mobilized into the blood, resulting in hypophoремia or decreased serum iron. So we learned how this condition occurs. So before we go into the pathogenesis of anemia associated with inflammation, what is the evolutionary significance? So how did this anemia start developing, and what is the evolutionary significance of this anemia of inflammation? So we know that whenever our body is faced with some infection, inflammation, the primary purpose, the primary function should be to bring down the infection or the inflammatory stimuli. So body tries to promote myelopoiesis and lymphopoiesis, and at the same time it will suppress other housekeeping processes such as erythropoiesis. That is one mechanism. And second is the something known as the nutritional immunity. So we know that iron is a very important essential micronutrient in our body. So just like us, even the invading or infecting microbes, for them also iron is a very essential micronutrient needed for their infectivity, pathogenicity, and also their proliferation. So in fact, during their evolution, these microbes have developed various mechanisms by which they will try to snatch away iron from the body of the host. So here you can see in this picture, they produce substances called siderophores, which will directly bind to the free iron for their utilization. They produce hemophores, which will bind to heme in the blood. Then they also have several receptors like transferrin receptors, hemopexin receptors, hemoglobin receptors, haptoglobin receptors. All this are aimed at getting iron from the host body. So what does our body do in such a condition? So the body, it will act smarter than the microbe. It will start storing all the iron within the reticular endothelial cells, and it will prevent the export of these iron which is stored in the reticular endothelial cells in the blood. In fact, it is a defense mechanism that is working here. Now, the same defense mechanism leads to the anemia. Now, coming to the pathophysiology, so as already said, all these chronic conditions have a basic inflammatory pathogenesis. So, the fundamental pathophysiology is the pathology is caused by the various cytokines released by the inflammatory cells. So the major cytokine 6 interleaved tumor. So most important mechanism is the production of hepcidin from the liver. So we'll learn what is the hepcidin. Secondly, this inflammatory act directly on kidney, major erythropoietin production. In this, cytokines will directly act on the kidney and reduce the secretion of protein in the kidney. And these cytokines, the third mechanism is that these cytokines also directly acts on the erythroid precursors, that is the colony forming units and the burst forming units, which are the earliest progenitors in erythropoiesis. So these cytokines will directly act on these progenitors and inhibit their proliferation. And lastly, the cytokines will also augment the hemophagocytosis. You know that the senescent RBCs are normally destroyed in the reticular endothelial cells by hemophagocytosis. Now, these inflammatory cytokines will augment this process of hemophagocytosis. So first and most important mediator of anemia of inflammation is hepcidin. This hepcidin is a hairpin-like peptide, 28 amino acid peptide that is normally produced by the liver in response to the iron level. So whenever iron is increased in the body, hepcidin will be produced and it will reduce absorption of iron into the body. Now this same mechanism is hijacked in inflammatory by the inflammatory cytokines. So here you can see that interleukin 6 and another cytokine is the activin B. These two will bind to the receptors of hepcidin. So you have this bond morphogenic protein and SMAD4 pathway here, SMAD pathway here, and interleukin 6 pathway is through the JAK-STAT pathway. So when these cytokines bind to their corresponding receptors, these downstream signaling pathways are activated, which will cause this phosphorylated SMAD and phosphorylated STAT to bind to the promoters of the hepcidin gene and cause the transcription of hepcidin gene and increase the production of hepcidin. So what does hepcidin do? So we already said that the fundamental mechanism happening is that all the iron gets stored in the reticular endothelial cells. So this is done by hepcidin. The receptor for hepcidin is ferroportin. Ferroportin is the only iron exporter that exports iron from the cells where iron is stored as ferritin. So the major cells where ferritin is present are one is the duodenal enterocytes where iron is absorbed. Then you have the macrophages in the liver and the spleen where normally the erythrophagocytosis occurs and the iron gets stored as ferritin. And also in the hepatic parenchymal cell. So whenever our body is in need for iron, this the iron gets mobilized from the ferritin and it is exported into the plasma through this ferroportin channel. But hepcidin will inhibit, it will bind to the ferroportin and it will cause it will be endocytosed. This ferroportin hepcidin complex will be endocytosed and it will be degraded. So once ferroportin is degraded, what happens? The ferroportin is the only non-exporter of iron into the blood. So when all the ferroportins get degraded, the iron cannot be exported in the blood and the stores start increasing while serum iron starts decreasing. So that is the role of hepcidin. Now coming to the second mechanism is the direct erythropoietic suppression. That is the inflammatory cytokines will directly act on the kidney and reduce the transcription of erythropoietic mRNA and thus reduce the production of erythropoietin. So the major cytokines are interleukin 1 and tumor necrosis factor. And another mechanism is, as already said, it is the increased red cell destruction. So these cytokines will activate the macrophages and increase the RBC destruction. And preferentially, normally the reticular endothelial cells of our body destroys the senescent RBCs. But what happens in anemia of inflammation is neocytolysis. That is, the newly formed RBCs are preferentially destroyed by the cells of the reticular endothelial system. And all these mechanisms will result in decreased RBCs and anemia. Now coming to the morphologic findings. So you know that basically the production of RBCs is suppressed by in anemia of inflammation. So basically it is a hyperproliferative anemia and it develops during the first 1 or 2 months of illness and thereafter it will not progress, and characteristically it will not be a severe anemia. Usually the hemoglobin levels will be maintained at a higher level, usually between 9 to 12 gram per deciliter. So whenever you see a severe anemia in this particular inflammation is to be maintained about 25%. This is the normal blood picture. Usually it is a normocytic normochromic anemia because of hyperproliferative anemia. But eventually, you know that the all of the iron gets stored in the reticular endothelial cells. So eventually, iron restriction is happening there. So in the long term, even though it starts as a normocytic normochromic anemia, it can eventually turn into a iron restricted anemia. That is a hypochromic microcytic picture can develop. And compared to iron deficiency anemia, the microcytosis is actually less striking, and hypochromia is what is more seen commonly than the development of microcytosis. And then the difference is that in anemia of inflammation, the development of hypochromia will precede the development of microcytosis, while it is the reverse in iron deficiency anemia. Coming to RDW, it will also be elevated, mild to moderate degree, and even that is also less prominent than in iron deficient subjects. And as it is a hyperproliferative anemia, the reticulocyte percentage and the reticulocyte production index all will be reduced, but it will not be the same degree as you see in other failure, bone marrow failure stage late aplastic anemia. But even then, because it's a hyperproliferative anemia, the RPI will be reduced. And the degree of anemia usually correlates with the severity of the underlying disease. So the diagnosis primarily and hyperferritinemia. That is, all of the iron gets stored in the reticular endothelial cells, resulting in hyperferritinemia, and it is prevented from export into the plasma, resulting in a hypoferrinemia. Now, this condition is known as functional iron deficiency. Now, this hyperferritinemia is not only because of the raised iron stores, but also because in infective and inflammatory condition, ferritin is a acute phase reactant. So the level of ferritin is actually higher than the amount of iron stores. And if you stain the bone marrow, we'll see that in the macrophages, the amount of hemosiderin will be increased. But the number of sideroblasts, which are the erythroblasts which are stained for iron stores, it will be reduced because of the functional iron deficiency. That is, erythroblasts are not getting enough iron for erythropoiesis. Now, more important is to differentiate anemia of inflammation from iron deficiency anemia. So, it is known that about 80% of patients with anemia of inflammation will also suffer from true iron deficiency anemia. That is because either it could be because of the disease-related or unrelated GI bleeding or urogenital bleeding, or because of multiple blood draws for the treatment of the primary condition, or because of other therapeutic procedures like hemodialysis. And particularly children are at increased risk for developing coexistent iron deficiency because they have a higher requirement of iron for the rapid growth. So, in a typical case of iron deficiency anemia and anemia of inflammation, the basic lab values are highly suggested. And just comparing, we will know that it's easy to differentiate an iron deficiency anemia from anemia of inflammation. So, now you know that in iron deficiency anemia, it will be a hypochromic microcytic picture. So, the MCV and MCH will be low, while it will be normocytic normochromic, it will be normal in anemia of inflammation. As the serum iron is low in both iron deficiency anemia and anemia of inflammation, the transferrin saturation, that is the percentage of transferrin is a transport protein for iron. So when the serum iron is low, the transferrin saturation will be low. So that is also same in iron deficiency anemia and anemia of inflammation. Now compared to that, you can see that TIBC, that is the total iron binding capacity. This total iron binding capacity is actually a proxy measure of the transferrin concentration. So normally in iron deficiency anemia, because the cells are an increased requirement for iron, the amount of transferrin in the serum will be increased. So TIBC, which is a measure of the transferrin concentration, TIBC will be increased in iron deficiency anemia. But in anemia of inflammation, the transferrin levels, the transcription of transferrin, the production of transferrin is decreased in anemia of inflammation because of the effect of the cytokines. So TIBC, or the transferrin concentration, will be low in anemia of inflammation, while it will be higher in iron deficiency anemia. Secondly, serum ferritin. You know that because it's an acute phase reactant and also because of the higher iron stores, in anemia of inflammation, the serum ferritin will be high, while in iron deficiency anemia, there is an absolute iron deficiency. In anemia of inflammation, it is a functional iron deficiency. So serum ferritin will be high, while in iron deficiency anemia, because of an absolute iron deficiency, there will be a low serum ferritin. Reticulocyte hemoglobin content. Now, this is the hemoglobin content in the reticulocytes. You know, the reticulocytes are the very young RBCs. So the hemoglobin content of these RBCs is reflective of the iron status, of a very recent iron status, because these are the young RBCs. So in iron deficiency anemia, the hemoglobin content of reticulocytes will be very low, while it will be normal in anemia of inflammation. And also the percentage of hypochromic erythrocytes, which will be higher in iron deficiency anemia, it will be low. Even in anemia of inflammation, hypochromic erythrocytes can be seen in long-standing infections, but the percentage will be lower in anemia of inflammation. Now, another important lab marker is the soluble transferrin receptor. So transferrin receptors normally whenever the cells or the erythroid cells or any human cell that is in requirement for iron, this transferrin receptors will be expressed on the cell membrane. And normally this transferrin mRNA regulation is carried out by this group of proteins known as the iron regulatory peptides. So these mRNA of transferrin receptors have these iron responsive elements in them, which will be regulated by these iron responsive proteins in response to the serum iron. So when there is high iron, the transferrin mRNA will be degraded, while when there is a low iron content or when the body is in need of iron, the mRNA will be stabilized. mRNA of transferrin receptor will be stabilized and increased transferrin receptors will be produced. So it indicates that in iron deficiency anemia, the transferrin receptors will be more. But in anemia of inflammation, the transferrin receptor concentration is not affected, it is not elevated. But one thing to remember is that when anemia of inflammation is complicated by iron deficiency, just like in iron deficiency, the serum transferrin receptor concentration can be elevated. So just to show that the various proteins, the change in plasma concentration of the various plasma proteins in response to infection, you can see that the ferritin can increase around 3000%, while the transferrin production is actually decreased by around 30%. So as already said, the soluble transferrin receptors are also one marker which can help in differentiating anemia of inflammation from iron deficiency anemia. But the problem arises when the ferritin levels are in a equivocal measure. It's usually when the ferritin concentration is very high. That is usually more than 100 nanogram per milliliter. It indicates that with a low transferrin saturation and a very high ferritin level, it indicates an anemia of inflammation. While a low transferrin saturation with a very low ferritin levels will indicate an absolute iron deficiency. So, but the ferritin is in an equivocal level like this, then one is that it can use as soluble transferrin receptor values, but when there is a coexisting iron deficiency along with anemia of inflammation, then we have to look for another ratio, that is the ratio of serum transferrin receptor to ferritin, because we said that the soluble transferrin receptor, even though it is unaffected in anemia of inflammation, when anemia of inflammation is associated with iron deficiency, the serum transferrin receptor levels will be raised. So in that condition, it won't help. In that condition, serum transferrin receptor will not help in differentiating iron deficiency from anemia of inflammation. In such conditions, this ratio of soluble transferrin receptor to ferritin will help in differentiating iron deficiency of inflammation. That is, when the ratio is more than 2, it indicates that there is a coexistence of anemia of inflammation with iron deficiency. When the ratio is less than 1, it indicates that it is an anemia of inflammation. Now coming to specific chronic diseases, one is the anemia of chronic renal disease. Now anemia is almost an invariable manifestation that most patients with renal failure will eventually develop anemia, just like azotemia. But the patients will be usually seeking medical attention for the symptoms of renal disease rather than for the anemia. And when we say anemia of chronic renal disease, we indicate the anemia that is resulting directly from the failure of the kidney, directly from the failure of the endocrine or filtering function of the kidney, because patients with kidney disease can also develop other forms of anemia, which I will be telling. So when you say it is anemia of chronic kidney disease, we are saying that the anemia is resulting directly because of the failure of the kidney. So what is the pathogenesis here? So one, we already said, anemia of inflammation is one of the mechanism of development of anemia in anemia of chronic kidney disease. But even more important or even more significant in the development of anemia of chronic disease is the erythropoietin deficiency, because we know that the kidney is the major site of erythropoietin production. So when the kidney fails, the erythropoietin production will also be reduced. In addition to that, there will be suppression of erythropoiesis and a reduced red cell survival. So how is the erythropoiesis suppressed? One is the anemia of inflammation-like mechanisms. Secondly, because of the failure of the kidney, various compounds will start accumulating in the blood. That is, the polyamines and other compounds will start accumulating in the blood, and these will suppress the erythropoiesis. Secondly, an important complication of chronic kidney disease is a secondary hyperparathyroidism because of abnormalities in calcium levels. Usually patients in chronic kidney disease can develop secondary hyperparathyroidism. This parathyroid hormone can directly suppress erythropoiesis. Also, secondary hyperparathyroidism can result in bone marrow fibrosis, and that will result in suppression of erythropoiesis. And another mechanism of anemia in chronic kidney disease is the reduced red cell survival. So one mechanism is neocytolysis, which we already said in anemia of inflammation. That is, instead of the aged or the senescent RBCs, the newly formed red blood cells are destroyed more in anemia of inflammation. The same mechanism happens in anemia of chronic disease. In addition to that, there are several other mechanisms. That is, because of the kidney failure, the red cells will be subjected to increased oxidant stress. Because of the electrolyte abnormalities, there will be abnormal cation transport in red cells. Also, various toxic compounds like guanidine metabolites and guanidine will be accumulated, which will be also directly toxic to the red cells, causing their reduced survival. So, as already said, not just anemia because of direct effect of kidney failure, patients with chronic kidney disease can also develop iron deficiency anemia because of blood losses or because of the retention of blood in hemodialysis tubing. Also, hemolytic uremic syndrome or thrombotic thrombocytopenic purpura can also develop associated with microangiopathic hemolytic anemia. So coming to the lab findings, predominantly the erythrocytes will be normocytic, normochromic, and the anemia will tend to become more severe as the renal failure worsens, but even then it will be only a mild to moderate degree of anemia. That is, it is usually the hematocrit will be around a mean of 25%. And in addition to that, we can see burst cells can be seen. In case of increased hemolytic blood picture, you can see helmet cells, schistocytes, and triangular cells can also be seen in the peripheral cells. You can see the burst cells with these regular spicules on the surface of the RBCs. That is a finding you can find in chronic kidney disease. Coming to the other blood lines, usually the leukocyte count will be normal, but a relative neutrophilia can be seen. The platelet count can be either normal or a mild thrombocytosis can be seen. But because of uremia, platelet function may be impaired in chronic kidney disease. Coming to the iron studies, it is maybe normal or decreased, and serum ferritin usually will be in the normal range, but if there is an inflammatory component, the ferritin levels will be increased out of proportion to the iron stores. Now coming to the other chronic disease, that is anemia of liver disease. Here again, just like in anemia of chronic disease, when the anemia is caused directly because of the liver disease without other complicating factors like blood loss or nutritional deficiency or marrow suppression by other exogenous agents, when the anemia is caused directly because of the liver disease, we call it as anemia of liver disease. And around 75% of patients with liver disease will eventually develop anemia. And one other factor in chronic liver disease is the hemodilution that is present in the patients, and that will actually exaggerate the degree and prevalence of anemia. And the hemoglobin levels will be usually maintained between 10 and 12 gram per deciliter. So whenever in a patient with a liver disease, whenever there is a drastic fall in hemoglobin levels below 10 gram, we should always search for other causes of anemia. So how does anemia develop in liver disease? One is the pathway as in anemia of inflammation, because underlying inflammation can cause anemia of inflammation. Secondly, in patients with alcoholic liver disease, the alcohol itself can directly depress erythropoiesis by suppressing the burst forming units and colony forming units, and reduce red cell survival, as seen in chronic kidney disease and anemia of inflammation. The same way, even in liver disease, red cell survival can be decreased. So these are the reasons for the decreased red cell survival. One is the congestive splenomegaly. The hypersplenism can cause destruction of the RBCs. In patients with alcoholic liver disease, this alcohol can inhibit the hexose monophosphate shunt pathway. Normally this pathway is what saves the red cells from oxidant stress. So when that pathway is inhibited by alcohol, the red cells get sensitive to oxidant hemolysis. And the common abnormality, metabolic abnormality seen in patients with liver disease is hypophosphatemia. Now this can result in reduced RBC ATP levels, and it can also cause hemolysis. And there are various alterations in the membrane lipids of red blood cells in liver disease. And now these alterations will reduce the deformability of RBCs, and it can cause reduced red cell lifespan. We'll see which are the alterations in the coming slides. Now, what are the other types of anemia? So when you say it is an anemia of liver disease, it is directly because of the liver disease. So, but other forms of anemia can also be seen in patients with liver disease. That is, alcohol abusers can characteristically develop secondary sideroblastic anemia. So that is because of the pyridoxine deficiency that commonly occurs in alcoholics, because pyridoxine is a cofactor in the synthesis of heme synthesis. That is, it is a cofactor of ALA synthase in heme synthesis. So because of that deficiency, alcoholics can develop sideroblastic anemia. So in that conditions, we will see this dimorphic bed picture. Siderocytes can be seen, that is red cells with these iron granules can be seen in the peripheral smear, and bone marrow examination can show ring sideroblasts, like in sideroblastic anemia. The other anemia that can occur in alcoholics or in liver disease is the megaloblastic anemia because of impaired folate metabolism. And patients with cirrhosis can develop iron deficiency anemia because of increased risk of hemorrhage. Another finding is the development of Spurs cell hemolytic anemia. In liver disease, patients can develop a peculiar red cell membrane abnormality known as the Spurs cells. And Spurs cell hemolytic anemia can also be seen in cirrhotic patients in around 10 to 30% of cases. So what are the morphologic abnormalities? So usually in liver disease, the RBCs are macrocytic in appearance, and the MCV is usually less than 114 femtoliter. So whenever the MCV levels are raised more than that, we should consider megaloblastic anemia should also be considered, and usually it will be mildly macrocytic. And two other findings are target cells and acanthocytes. So in liver disease, there will be, because of the there will be abnormalities in the cell membrane lipid concentrations. So it can show both a balanced increase in cholesterol and lecithin in the RBC membrane can occur in liver disease. In that case, because of an increased membrane surface area, because of increase of both cholesterol and lecithin, the red cells can form target cells. Another finding is the development of acanthocytes. That occurs when there is only the accumulation of cholesterol in the outer lipid layer. So when there is an increase in cholesterol in the outer lipid layer, the outer membrane of the RBC starts forming these spike-like projections, resulting in the formation of acanthocytes. So here, these are the various blood findings. You can see macrocytes in liver disease, target cells because of the excess of cell membrane. And these are chondrocytes here because of excess of cholesterol on the outer lipid bilayer, forming these small multiple irregular projections on the red cell surface. So coming to the therapy in anemia of inflammation. So always before branding a patient as anemia of inflammation, you should always rule out other causes of hyperproliferative anemias, which we will be seeing. And once we know that the anemia is because of the underlying disease, if you effectively treat the underlying disease which is causing the anemia, usually it will resolve the anemia. But sometimes the anemia will not be resolved by the treatment of the underlying disease. Then we should give specific treatment for improving the hemoglobin, which includes the erythropoiesis stimulating agents, intravenous iron, and sometimes blood transfusions might also be required in these patients. Now coming to the abnormalities in endocrine disorders. So first coming to hypothyroidism and hyperthyroidism. In hypothyroidism, you can see either it can be normocytic anemia, macrocytic, or microcytic anemia can be seen. So basically, hypothyroidism is a hypometabolic state. So what happens is that the normal cellular oxygen demand itself is reduced in a patient with hypothyroidism. So as a result, the hypoxia-induced production of erythropoietin will be decreased. So it is one cause of anemia. And secondly, because of hypothyroidism, the normal effect of erythropoietin on the erythroid colony formation will be dampened. Usually, thyroid hormones will accelerate the effect of erythropoietin on the erythroid colony formation. So when there is hypothyroidism, the effect of erythropoietin is decreased. While coming to hyperthyroid patients, so as hypothyroidism is causing anemia, you might consider that hyperthyroid patients can go into erythrocytosis, but in fact 25% of patients with hyperthyroidism will also eventually develop anemia, and that is due to the increased plasma volume in these patients. And usually when you treat the patients with anti-thyroid drugs, the anemia will be resolved. Coming to androgens and estrogen, androgens are known to stimulate erythropoietin production, and also these androgens directly act on the erythroid precursors to increase the production of RBCs. So that is why there is increased hemoglobin levels are seen in sexually active males compared to females or older and younger males. You can see increased hemoglobin. That is because of the erythropoietic effects of androgens. But effect of estrogen, there are conflicting. Some studies shows that it increases RBC production, but some other studies shows that anemia occurs because of the effect of estrogen. Coming to adrenal gland disorders, the adrenal insufficiency is usually associated with normocytic normochromic anemia, while Cushing's disease and aldosteronism is associated with erythrocytosis. And pheochromocytoma, which is an adrenal medullary tumor, it is associated with erythrocytosis, and now that is because of the autonomous production of erythropoietin by the tumor itself. About pituitary hormones, usually deficiency of anterior lobe hormones, that is the adrenocorticotropic hormone or the follicle stimulating hormone, thyroid stimulating hormone. So the deficiency of these anterior lobe hormones is known to cause suppressed erythropoiesis and cause a moderately severe normocytic normochromic anemia. But the posterior lobe hormones does not have this effect, that is the vasopressin or the oxytocin doesn't have this effect. So basically if you replace the corresponding hormones, that is the thyroid, adrenal or gonadal hormones are replaced, the anemia and other cytopenias can be corrected. In addition, the one growth hormone, which is also an anterior lobe hormone, that is also a hormone which will accelerate erythropoiesis. So when growth hormone replacement therapy is given in children and adults with the growth hormone deficiency, hemoglobin levels are seen to increase. Coming to parathyroid hormones, both primary and secondary hyperparathyroidism is known to cause fibrosis of the marrow, that is known as a secondary myelofibrosis. So because of myelofibrosis, it can result in anemia and pancytopenia. So how does hyperparathyroidism cause this fibrosis? It is because it will activate the osteoclast and cause elaboration of various cytokines and paracrine factors in the marrow, that is interleukin 1, interleukin 6, transforming growth factor beta, tumor necrosis factor alpha. All these will be produced, which will cause fibrosis of the marrow. This secondary hyperparathyroidism is a non-complication of chronic kidney disease. So that is also one of the reasons of anemia in chronic kidney disease. So in these conditions, if you medically treat the hyperparathyroidism or if the parathyroidectomy is done, anemia will improve. So before we conclude about hyperproliferative anemia, so as already said, anemia of inflammation is a hyperproliferative anemia. That is that we diagnose hyperproliferative anemia by testing for the reticulocyte index. So when the reticulocyte index, reduction index is less than 2, it indicates that it is a hyperproliferative anemia. So besides anemia of inflammation and kidney disease, all various other conditions also cause decreased erythropoiesis. So all of these conditions should be kept in the differential diagnosis, and a systematic manner of should be followed in coming to a final diagnosis. So detailed history and physical examination should be done, and including the iron studies, peripheral smear examination, and we should also do the renal function test, liver function test, vitamin B12, folate assay, LDH and haptoglobulin to rule out any hemolysis. All this should be done, and if the etiology is identified, we can treat it. And even in spite of these initial studies, if the diagnosis is not clear, we will have to go in for bone marrow aspirate biopsies. Okay, that's all. Thank you.
Thank you, Dr. Jaya. Wonderful presentation. Very detailed and almost covering everything. Each and every endocrine activity as well as inflammatory process. And like you rightly said, it's primarily not only the inflammatory process, but the primary disease causing the inflammation, which also contributes to the anemia. Wonderful presentation. Just let me see if there are any questions on the YouTube. Just hold on. You can stop presenting and share your video so that we can see you.
No.
Video of your videos. Yeah, that's right. Right. So there are no questions. Thank you so much for this wonderful presentation. I can't hear you. I think you are muted.
Yes. Yes, I would also like to thank all the organizers of this NELAM Pathology Conference. It's a very great opportunity for me to be able to present in this forum. Thank you so much.
And the honor is all ours. It's a pleasure to have you here. Wonderful classes, 2 of them, basics, but very interesting and very informative. I would request you to share the PDF so that we can share with everybody. And thank you so much. God bless you. Good night. Take care. Bye-bye.
Thank you.